I'm Brian Dixon, the Interim Director for the Center for Biomedical Informatics here at Regenstrief. It is my distinct honor and pleasure to introduce our distinguished lecturer this afternoon. Dr. Saira Haque is the Senior Director for Clinical Informatics at Pfizer. She's been there in that role for 2 years now. Prior to that, she was the Senior Health Informaticist at the RTI International, where she had been for a decade. And so Saira has her PhDs in Information Systems and Technology. Her master's is in Health Policy and Management from Michigan, which is nearby. But over her career, she's worked quite a bit in, especially in telehealth, and has testified on the Hill around telehealth issues, including access, reimbursement, et cetera. So I've known Saira for a long time through the American Medical Informatics Association, so I consider her to be not only a great colleague, but also a wonderful friend as well through that. And she's worked with many people here. Are you going to talk about any of the work that you've done with like Randy or? Not today, okay. But she's worked with Randy Grau. Yeah, she's worked with several people at Regenstrief over the years. So we are delighted to welcome her to Indianapolis and to our building here at Regenstrief. So without any further ado, I'll turn things over to Saira. Please join me in welcoming her to the podium.
Thank you so much, and thank you all for having me. It's my pleasure to be here. So as Brian mentioned, I've had a number of roles over the years, and I'm going to talk a little bit today about some work I've done across institutions. So today I'm going to talk about digital health tools from promise to practice. So we'll cover 3 main learning objectives today. The first is that I will describe some potential uses of remote patient monitoring, and then talk about how digital health tools fit into the virtual care landscape generally. And then finally, we'll talk about some considerations for organizations when they're incorporating these tools into practice. So we'll do this in 4 parts. One is I'll provide a little bit of a background, and then talk about 2 projects in which I have been involved, and then we'll talk about future directions to close. These are my disclosures. Basically, this is not an official viewpoint of anyone except for myself. All right, so let's start with the background. So first, I thought we could level set by talking about what virtual care is. You hear a lot of different definitions and terms that people use interchangeably, and that could be, telemedicine, telehealth, e-health, e-visits, all kinds of things that people refer to. And all of those have a slightly different nuance depending on who you're talking to. But no matter what the term is, overall, virtual care I consider an umbrella term that encompasses all of these and involves interactive information exchange to support all aspects of care. So regardless of the definition, that's what we mean when talking about virtual care. Now, virtual care has had a lot more attention recently because of the pandemic, but in fact, it has a long-standing history. So actually, the year that the telephone patent was first filed by Alexander Graham Bell, there was an article in The Lancet about the potential of using the phone to reduce in-office visits. So really, it's been since the 1800s that various aspects of virtual care have been in place. Now, as technology use has increased, as communication innovation has happened, and as things like the telephone, broadband, et cetera, have been more widespread, there's also been more attention paid and more advancement across virtual care. And so now the focus is not so much on implementation, but more on sustainability, population selection, how to address changes in innovation, et cetera. So now it's really moved forward. And of note, NASA and the VA have actually been pioneers in this area. And one reason is that they're not subject to some of the policy restrictions. So for example, you don't have state licensure for astronauts because that doesn't really apply. So there's things like that that make it a little bit easier for those agencies to be pioneers in this area. There's 4 main types of virtual care that CMS recognizes. So the first one is live visits. So that's synchronous communication, and that can be by video, by phone, or maybe through various apps, etc. The next is what we're going to talk the most about today, which is remote monitoring. So that involves asynchronous communication between a patient and a provider who are not co-located. Next is store and forward, and so that involves asynchronous communication between providers. And radiology and pathology are the most common. However, it can across specialties. It's just that those are the ones that kind of lend themselves the most to store and forward. And then finally, there's mobile health or mHealth, and this is very much related to remote monitoring. It didn't used to be that remote monitoring devices had a smartphone component, but now they pretty much all do. So some of these divisions are a little artificial, but that's an example of how sometimes technical innovation and policy and regulation are not aligned in pace. Virtual care can address a number of different challenges. The first is access to care, not only access in general, but access to culturally competent care, access to certain specialists, access close to a patient so they don't have to travel, et cetera. The next is geographic isolation. So I did some work in frontier areas where people would have to drive, 500-600 miles to get to a specialist. And so in those cases, it's really difficult to maintain compliance. So there's really, and then also there's places where, in the winter you can't get to. So there's, different kinds of seasonal variation, et cetera. So virtual care can help address some of those kinds of challenges. But you don't have to be remote. Sometimes people can't have transportation for a variety of reasons. And then finally, provider burnout and workforce shortage has been had a lot of attention recently, but in fact, this has also been a longstanding problem in many areas. And virtual care can help address some workforce challenges by offering patients and providers even a chance to work with people across who are not necessarily co-located. So now let's talk about remote monitoring. It used to be that there was one term, just remote monitoring or remote patient monitoring. But then as technical innovation has continued and as remote monitoring has expanded, CMS has actually split this out. So now remote monitoring is an umbrella term, and there's 2 different types. The first is remote patient or physiologic monitoring, and the second is remote therapeutic monitoring. So remote patient monitoring involves looking at the patient's vital signs, looking at their biometric data, et cetera. And it can be ordered and used by both prescribers and also other clinical staff. And typically the devices can be condition agnostic, so things like steps and overall health and wellness. Remote therapeutic monitoring is a little bit more specific. And so this includes, it can include patient-generated data that's non-physiologic. So for example, with a continuous glucose monitor, a patient could enter, I had a donut at the same time or something like that, or they could add, I felt dizzy, things like that. So that way, providers have a little bit of context for the numbers that they're reviewing. And of note, this excludes clinical support staff. So this is limited to prescribers, and there are some use cases for virtual physical therapy and occupational therapy. And as such, because it's more specific, the devices are also more specific. So they're limited to those with that measure various musculoskeletal and respiratory symptoms. So that's a primary difference. And this is not actually very well known. It's pretty new and came out some of these divisions. So it's taking providers a little bit of time to catch up, which is pretty typical for when there are changes. So as I mentioned earlier, that sometimes it takes a little bit of time for the regulatory landscape to catch up to digital innovation, and that digital health tools are no exception. There's a lot of technical innovation that's happening very quickly, and the developers and the device manufacturers are very excited about some of these changes. However, providers, organizations that in which providers are housed, and government agencies did not necessarily ask for these changes. They just sort of are there, and then they have to quickly innovate and move to adjust to those changes. And so the FDA has actually added some different types of device classes. One is software as a medical device, and the other is a mobile medical apps class, and because they had to figure out how to accommodate that. Within software as a medical device, there are 3 different categories. One is digital health and wellness tools, so those would be more appropriate for our PM, as I discussed. They're a little bit more general. Then the next 2 are aligned more with therapeutics, so digital medicine, products that can measure or intervene, and then digital therapeutics, DTX, which are products that typically will intervene. So as I said, there's kind of this whole cycle with measurement and intervention. So some tools are measurement only, which means that they will measure something, and then the provider, you can see kind of that first arrow, the provider will make the intervention based on their review of the data. Sometimes with the tool itself, the tool can actually can intervene. So that's kind of on the right there where it says intervene with digital therapeutics. And then you see the effect of it and measure again. So it's kind of like this continual cycle. So there are measurement products, there are intervention products, and then there are combination products that are both. And so that's just important to understand when looking at the landscape, because there are so many different things that are coming out. And product is, I'm using it very generally. It can be hardware, software, or both. So now that we've talked about that, let's talk about what some of the devices are. There are a whole host of devices. I have a smartwatch on. How many people have a smartwatch on, by the way? Yeah, see, a lot of us have a smartwatch on. So some of those are general consumer wearable devices. Some of them are actually FDA cleared to detect signs of irregular heart rate. Apple recently added a glucose sensor. There's all these different kinds of things that are out there. So some of them you can buy on Amazon, the consumer wearable ones. They're used for everyday health and fitness, track your steps, monitor your calories, things like that. If any of you are older, you might remember those commercials. I've fallen and I can't get up. With the life alert, that was remote monitoring in a way. So there's all kinds of things that are out there. Now there are others that are provider oriented. You can't really get a pacemaker on Amazon. There's things like that are or augmented reality, so virtual physical therapy, where the physical therapist can see you and make modifications to your form using these kind of glasses. Medication that's delivered through wireless patches that can also check to see what the levels are in the blood. And then advanced durable medical equipment, such as oxygen tanks, which have the capability to adjust oxygen levels within certain parameters, et cetera. So there's a whole host of devices. And that picture there really covers more the consumer wearables, but it's kind of interesting to see just how many different things that there are. The devices can monitor or track a whole variety of things, and really it's changing every day. These are just a few examples, but the idea is that what started as sort of rudimentary, maybe tracking, has really expanded, and I anticipate that it will continue to expand. So there's a whole host of things that can be used and a whole host of kind of functionality that we may even all have on our home devices that are being expanded as we speak. So there's a number of different ways in which remote monitoring can be used. One is disease management, both for chronic and acute disease. The next is for behavioral health, and that includes things like substance use disorder, medication-assisted treatment, et cetera. There's also transitions of care, and this can be transitions of care between settings, across providers, or perhaps in a short-term thing like post-surgery, that kind of thing. And then also to address the aspects of social determinants of health, monitoring social needs, looking at environmental challenges such as air quality, and to address transportation needs, because by remote monitoring, then patients don't necessarily have to travel. Now, of course, it sounds great. There's all these different things that can be reviewed, but how does it actually happen in practice? There's a number of different organizational considerations. The first that I'm going to talk about is financial. So the reimbursement and the regulatory landscape is changing. It changed before COVID, during COVID, and now in whatever state we're in with COVID. But it changes all the time with payment parity, provider parity, who can bill, all those kinds of things. And that also is different for different types of virtual care, e-visits versus quick check-ins versus remote monitoring. And so this is changing across providers, and it's difficult to keep up. Also, the return on investment. If organizations are adding different functionality, if they're making workflows, adding staff, what will the return be for them? Will it be a loss? How does this work? The next is regulatory. With cross-state licensure, that's a really big concern, particularly with remote monitoring. Are providers going to maintain licenses across states? How does that work? The malpractice territory is really uncharted, and it's not really known how this will change with the advent of more remote monitoring and virtual care. And then finally, credentialing across institutions. Providers are reluctant to get credentialed across a whole number of institutions because the process is onerous and time intensive. And similarly, institutions are loath to use delegated credentialing because they don't necessarily feel that other organizations represent their values and their parameters for credentialing. So that's a big barrier for all aspects of virtual care. Then there's technology and associated infrastructure. So that can include technical and interoperability challenges, having broadband. We still have so many areas with broadband deserts in the United States. Connectivity, physical infrastructure, actually even thinking about, where are computers located, are providers in a room that's quiet and private and has good light, all those kinds of things. Then finally, I made organizational kind of one big bucket, but it really encompasses a lot. It's looking at what are the various workflows, how does one respond? Sometimes people have the idea that remote monitoring and virtual care are on demand, and very few people operate that way because who has time? So there's kind of managing expectations all around, and then the associated workflows. And then of course, looking at patient and provider acceptance and education, thinking about when a virtual solution may or may not be appropriate and for whom. Perhaps it's across different types of service lines, perhaps different populations, et cetera. So all of those things are things that, in the beginning of the pandemic, there was a big push to move as much virtual as possible, and rightfully so, given what was happening at the time. However, moving everything virtual is not really a long-term sustainable solution. So then now the idea is to think about, well, what should be virtual? What can be done in person? And for whom? There are, of course, some patient-level considerations that we should also think about. There are some patient-related factors that relate to acceptance and use. One is digital and health literacy. A large portion of the population is not literate in general. And then we go to health literacy, and then we have digital literacy. So those are all three different aspects of literacy that we have to consider when looking at virtual care and remote monitoring, because it really does require a lot of the patient. We're all informaticists, so sometimes we forget. If anyone has done remote troubleshooting for a parent or someone in another state, you have to really think about what are the steps and how do you tell someone what to do. And that can be really frustrating. And you might not even think about the steps because it's so innate to the person who does it all the time, but it's not innate to this person who is just trying to get care, and perhaps they're worried about their health and have a whole host of other issues. One marker, and particularly for older adults, is if they can see or hear well enough to watch TV, or if they have a physical paper, read a paper, then they probably could see enough to maybe manage a device. But if they can't, which a lot of people can't, then it's not really a reasonable expectation that they would be able to manage for virtual care. And then similarly with motor control and the ability to use it. The buttons are small, sometimes the font, that kind of thing. And then technology acceptance. Some people love it, and some people would rather do anything else and not have care rather than have an electronic solution. So those are all things to think about. And then, of course, there's technology-related factors. Who has access to the internet with a reliable high-speed connection? Who has access to an internet-enabled device? And who can actually use it? Do they have general internet knowledge? So those are all things to think about when thinking about patient selection. Then, of course, there are some overall factors that might promote adoption and use, and those include value-based funding arrangements, because then some of the regulatory landscape around payment doesn't apply. having clinical and administrative champions, enough technical capability. If an organization or a small office is they still are running with paper shadow charts, it might be hard for them to kind of do this more advanced functionality. Having patient and caregiver demand. There might be people who are very interested, or maybe their adherence is low, they can't come in for visits, so there might be reasons to think about with the population. And there might be specific conditions for which this is appropriate. So those are just some things to consider. So now that I've talked a little bit about the background, we can probably get into what's actually a little bit more fun, is to talk about a few different specific projects in which I have been involved. So the first one is consumer wearable devices to help detect signs of atrial fibrillation, and that's something that I'm currently involved in. So before we get too into the project, I'll just level set a little bit on what atrial fibrillation, or AFib, is. It's actually the most common type of heart arrhythmia, or irregular heartbeat, in the United States. And it's, by some estimates, almost 12 million people will have it by 2030. It's largely underdiagnosed, and one reason is that there's frequently an asymptomatic presentation. Some people may feel that they have an irregular heart rate and come in, but other times someone might just think, well, I had too much coffee and I'm not really sure what's going on. And the reason that it's important is because it's associated with a number of factors, such as death, heart failure, and stroke. And strokes that are caused by AFib are more severe than strokes that are a result of other factors. Unfortunately, almost 20% of AFib is diagnosed at the time of stroke, which is not too late per se, but perhaps if it had been diagnosed earlier, then that stroke could have been prevented and maybe wouldn't have been as severe if the person had been under treatment. So it's really important to think about how to reach the under or undiagnosed population. So as I asked earlier, who has smartwatches? Many of us do. If you have a newer smartwatch, chances are it's FDA cleared to detect signs of AFib. So it's probably FDA cleared to detect irregular heart rate. And there's a few that are FDA cleared, the newest Apple Watch, Samsung, Withings, Fitbit, and the Google one. There's all kinds of, it's adding all the time. And so, but this is an example of the developers were like, this is great, we can do this. And healthcare organizations were not necessarily asking for this. And in fact, they were not prepared because patients are calling or saying, hey, I got this device, what do I do? And providers are thinking, they don't necessarily have a standardized way to handle it. There aren't really pathways for automated information exchange. The ECGs cannot be automatically transmitted. So we sought to understand this a little bit more. And so to help healthcare organizations, because there are big studies like the Apple study, the Fitbit study, but those are studies and they don't necessarily reflect what happens with organizations in practice. And so we sought to understand and identify best practices regarding managing AFib alerts and develop and test resources. And the reason is because, as I mentioned, the evidence-based is really characterized by pilot or feasibility studies, and some of them are very large, but they don't necessarily reflect what happens in practice. The studies were more focused on, does this work? What's the false positive rate? Things like that. There are some surveys about healthcare provider perspectives, but before ours, most of them were international in scope and don't reflect the US healthcare system. And there was not necessarily a whole host of tools and resources to support operations. So I'm going to talk today mostly about the provider survey. So first we did a literature review to look at what is in the literature around this and identified some themes. That paper is under review, so maybe next time I'll talk more about that. But now I'll just say that we took the themes from that lit review and used that to develop the survey. So that way we weren't repeating what we already knew, but really adding to what was a gap in the evidence. And we focused on understanding provider knowledge and experience with consumer wearable devices, how they manage data from patients who have an alert, and what happens in that process, barriers and resource needs. So we distributed the survey electronically across the country. Most of the people who responded did take care of AFib patients as part of their usual practice. There were 9 who didn't. There were like urologists and things like that that we excluded since AFib is not typically part of their practice. So just some highlights from the survey. So about a third said that they regularly receive notifications, and they receive them all different ways. Sometimes during a visit, someone would say, hey, by the way, I got this alert on my watch, what do I do? Sometimes people would call the office, sometimes a message in the portal, either directly to the provider or to their staff. And there were all different ways that they would like to receive the alerts. Some preferred through the portal with some triage, so to have someone else manage the messages initially, and then they would get the ones that perhaps were a little bit more severe. Some wanted them to say it during the visit, some wanted them to message them directly. And then how people respond to the alerts also varied. Sometimes the response was to ask for an ECG tracing. So when you get an alert on the watch, you can actually take a tracing, save it as a PDF, and send to the provider. Some would refer to follow up directly, sometimes do a visit, either electronic or in person. Some would refer for further screening, and others would wait and see. And it would depend on a variety of things, who the patient was, their other factors, et cetera. But there were a number of barriers that they identified to using the devices in practice. There was a big concern about the potential for false positives, and there was also some confusion around what an alert actually means. What the alert on the watch means is that irregular heart rate was detected. It doesn't necessarily mean that one has a diagnosis of AFib. However, all the device manufacturers call it an AF alert, or sometimes they call it an AFib alert specifically, so that can be a little bit confusing. There's also a lack of documentation and processing standards in the EHR, and this varies across systems. So we actually, as part of this work, talked to some of the EHR vendors, and even some of the people with whom we spoke were a little surprised by the lack of integrative functionality. So that was a fun conversation for me, because I was telling them about what they had going on, but it's complicated, in fairness. Also, the devices that have FDA clearance changes. It changed even during the course of this work. And professional societies have come out with white papers acknowledging that consumer wearable devices may have a role to play, but they don't say what that role might be or provide some guidance, so that can be confusing. Similarly, there's a lack of workflow standards. And then, there's a lot that's out there about data overload and provider burden in general, and some people perceived that this is just another thing that providers have to manage. And then finally, there's kind of thinking about what is the balance between observation and screening? When do you decide to refer? And that's something that a lot of providers cited. In addition, we followed up with some interviews and used that to inform development of resources. And so that is another paper that we have under review, which next time we can talk about. But some things to think about for the future are the concerns about digital and health literacy, whether or not patients are even available or aware of this functionality and know how to use it, thinking about the workflows, who actually responds, how does this work, and where does the data actually appear. A lot of times patient-generated data sort of appears on the side. It's not really integrated with the rest of the chart, and this is no exception. And then there was really an overwhelming desire for proactive educational resources, educational for clinicians, for their staff, for patients, and for caregivers. And so really to tailor it to different populations and to think about how to incorporate all this information and what to do with it. So as I mentioned, we have a few papers in progress, and then the survey, which was presented at the American College of Cardiology meeting this year. The next thing I'd like to talk about is the Tango study. So we'll move from a consumer wearable device to a continuous glucose monitor, which is not something you can get on Amazon. So this study, the Tango study, focused on type 1 diabetes in patients over 65. And it didn't used to be that there were very many type 1 diabetic patients over 65, but life expectancy has increased, and so has quality of life for these patients, which is great. However, this population is at higher risk of hypoglycemia and the negative consequences, and they also vary a lot. Some of them are very robust. They only have type 1 diabetes, and they can live on their own, and they're quite healthy otherwise. And some might require some care. Others are perhaps in facilities or need help with their activities of daily living. And this population is more likely to have multiple comorbidities with the associated specialists and treatments therein, so that it presents a coordination challenge. And this population is less likely to adopt continuous glucose monitors. And so we sought to understand an approach that would be individualized and include both the CGM and also a diabetes management program, which is personalized education delivered by a tablet. So here, the TANGO study, that's what it is, technological advances in glucose management in older adults. And so the main aims were to understand the impact of the eCGM program, which is the device plus the education. And then the second aim was to understand barriers to using diabetes technology in older adults. And the study period started in 2017, ended in 2022, and it was extended a little bit due to the pandemic. We wanted to extend it longer, but the funding mechanism required an act of Congress to extend it longer, and Congress did not have our funding mechanism on their top list of priorities for some reason. So we went to 2022 in October. And then you can see there who the sponsor and collaborators were. So I'm not going to go through this in great detail, but the idea is that we were looking at type 1D patients above 65 who are insulin dependent and who were in decent health, meaning if they had poor glycemic control already, or if they had maybe a skin condition or some other factor that would prevent them from using the CGM, that they were not included, because then there might be other confounders. And so people had extra visits during the study period by the study physicians, and everyone else had usual care. The diabetes management platform was more customized for the study population versus everyone else who got a tablet with different types of education. And there was clinical decision support based on the CGM data that the study physicians could choose to use or not. So going back to that diagram, it was measure, not intervening by itself. And the control arm just, again, had usual care. And we also did interviews. So the primary measure that we were looking at was the change in duration of hypoglycemia. And the other outcomes, some of them were measured by the CGM. Some of them were measured through labs, so A1C. We also had number 5, which is a cost effectiveness component, and an assessment of barriers and facilitators, which is the qualitative component. So there were a couple changes during the study which impacted our work. One is that before the study, Medicare did not cover continuous glucose monitors. It was not covered for people over 65, but then that changed, in which case usual care could include the CGM because it became part of usual care. So that happened, which had to, we had to think a little bit about the cost-benefit analysis, since obviously that changed. And then the second change was the pandemic, which obviously changed things quite a bit. We're not going to have a population of patients over 65 with diabetes coming into the office, going to the lab. That would not be a smart move. So everything was moved online. There were no in-person clinical or lab visits for a few months. And so then we thought, what do we do with our study team who is supposed to be seeing all these patients and helping them during visits? So we conducted semi-structured interviews with this population to understand how they were adapting to the pandemic, troubles with their technology, things like that. And then, as you know, things kind of move along. So I'm going to talk a little bit about that while the other analyses are still ongoing. So we looked at the CGM data for this population for a 2-week period before the lockdown and during, to see if there were any changes in those outcomes. And then we also, as I mentioned, did semi-structured interviews and analyzed those. So they actually did pretty well with their time in hypoglycemia. They stayed within range. You can see there with the p-values that there really wasn't that much of a change. Honestly, which is usually you're not very excited by having a non-significant p-value, but in this case we were glad because it meant that they were managing their diabetes pretty well. So that was something that I thought was really interesting. We weren't sure what to expect with, particularly given the interviews, so this was nice to see. In terms of the interview results, we categorize them into two different categories. So one is psychosocial considerations, dealing with managing their diabetes, the pandemic, and overall well-being. And then the second large category was the impact of isolation on their use of diabetes technology, technology for social interaction, and then technology to maintain their medical care in general. And I won't read all the quotes out loud to you, but on each of these themes, I have one. And I think that really kind of helps bring home what some of the themes were. And while we're talking about a particular use case, some of the things that came out, I think, are really useful when thinking about this population in general and when thinking about technology across disease states. So the first one was on managing their diabetes. People were really worried about hypoglycemia. I almost feel like perhaps that we did too good of a job as a study team on education about some of the risks, because that was the first thing that came to mind quite a bit, in fact. And then the second thing that came up, really almost every person was worried about the supply chain. If you recall, in the beginning of the pandemic, there was supply chain problems really for everything. And then for people who needed diabetes supplies, you could only get them for a certain period of time. You can't really stock up anyway because of the Medicare rules. And then there was an interruption in supply chain. People were very nervous, and rightfully so. Some were worried about virtual visits. They had never done it before. Like, how's this going to work? What would happen? Some were concerned about how they would manage their diabetes. Someone said, I can't go to the Y anymore. I used to go there all the time. I would see my friends and I would walk. What do I do now? I can't get groceries. My kids have to get them for me, and things aren't available. All those kinds of things were concerns. There were also some pandemic-related concerns, especially before the vaccine. This was all before the vaccine. And so people, this is a high-risk population, so they were nervous about what would happen if they contracted COVID. We also heard quite a bit about the feelings of a lack of reliable information on the pandemic, and the first quote there really exemplifies that. And I think that's an opportunity to think about targeted scientific communication and targeted technology-related communication, because this was something that came up quite a bit. And then others, these were all seasoned patients with diabetes. They had type 1, they're over 65. So one of them told me, I've had diabetes longer than you've been alive. I know how to manage it. And I've said, yeah, you're right. I mean, because both of those things were true. But she was nervous about the technology. But some of them said, the second man, this quote, he said that whenever he had a virus or was feeling under the weather, he would actually see those results, like he would see effect on his sugar. And so he thought, well, if I get COVID, maybe if I track it, I'll know a little bit ahead of time, and that maybe that would help me. So I thought that was interesting that people took what they learned in general and applied it here. Next, there was concerns about overall well-being. People were very nervous in the beginning and locked down. Some of them lived with a partner or family. Others of the participants lived alone. Regardless, there were persistent feelings of isolation, loneliness, not being able to spend time with their family, not being able to do their usual activities. And then, it was a stressful time in general. And then, being that time obviously was even more stressful for them because they were at high risk. So that's something that came up quite a bit. And people were, this woman here, she was actually, her kids and grandkids, they were afraid to see her. They didn't want to put her at risk, but then she missed them so much. So it kind of went to this cycle, and then that affected her well-being. Now, the next set of themes relate to the use of technology, the use of CGM to manage their diabetes, the use of the insulin pump, and then thinking about how to get their medical supplies. The process to get supplies is actually pretty confusing for a lot of people. There's a website, you can only get it for certain periods of time, and then you have to kind of check your insurance and the shipment, and sometimes the timings don't align. So this man who was 77 mentioned that it was complicated and a lot to manage, and he said, I can do it now, but will I maintain my mental ability to do this? What happens 20 years from now? And I'm not sure that the processes are going to get less complicated and less web-enabled. So those are very real concerns, and I think they all heightened during the pandemic because everything had moved virtual and they couldn't go to the office and get help where previously they could have. The next theme involved social interaction. So some of the groups that people were a part of moved to Zoom. Someone mentioned, churches and temples and other places of worship had moved their study groups online so they could continue to talk and interact. Others didn't. One person was part of an insulin pump support group, this person here with this quote. And it was interesting that more people participated than perhaps did in the past. And other people, by the end, were a little bit sick of it. And so it's interesting to see how that worked. And they learned how to do Zoom. One person said, it took her a little bit, but her granddaughter helped her and she figured it out and then she used it all the time. The next technology related theme involved medical interaction, so using technology for medical care. So one was they all had to get used to virtual visits. Not one person had done a virtual visit before. This was their first time. And so, that was, certainly something to get used to. If you think to someone who hasn't used Zoom, who has not had a virtual visit, it's a lot to kind of think about and adjust to. And some were concerned about the ability to receive usual care. In the beginning, the guidance was changing as the public health emergency was declared, and some of the requirements were changing. So for example, as you can see in this quote, for Medicare, it's a requirement that people with diabetes be seen every 3 months and have an A1C done in the laboratory. Well, everything shut down. People needed supplies, they wanted to continue, but they couldn't do that. So then people were really nervous, like what's going to happen? In fact, Medicare did change those rules to make an accommodation, but at this time, it wasn't, the communication was tough, and I don't think it had happened at this time. Also, people were concerned about the lack of physical exam, like a foot exam and things like that. That can be hard to do virtually, particularly if you're not used to virtual care, and then you're trying to show someone your foot and the light is not that great and you're trying to manage your smartphone, and these are all older people. So, I know my flexibility is not as good as it used to be, and I am not over 65. So when you think about it, there's a lot of things to manage, and if they don't have someone there with them, that's a lot. And so that was something else that came up. But overall, the participants really found the use of the CGM beneficial overall during the pandemic. And then, there was some variation in how comfortable people were with technology, if they wanted to continue. Some people wanted to continue after. They're like, I like virtual care. I think it's great. Others could not wait for this to be done so that they could go back and see their physician in person. The supply thing came up quite a bit. And so, that's something that is of note. And then the next couple I think are interesting because people were not necessarily aware of changes in rules, and people really did require quite a bit of assistance in managing the changes in rules, managing how to get the supplies, getting on Zoom. So really having some structured assistance and building that in might be something useful to consider for the future. But people overall did appreciate being able to see the data, as you can see from this quote from a man who had been a patient for 44 years. So that was about the COVID-19 work. Overall, though, the rest of the study did continue. We continued on after and continued with study visits. And so the analyses are still in progress. Preliminarily, there have been some improvements across the aims. It varies how what they are, and when the paper is out, I guess we'll see. And the cost-benefit analyses, that one has been a little bit of a challenge because usual care expanded to include what we were testing. So we'll have to look and see a little bit about what to do with that. In terms of the qualitative analysis, overall, participants had a positive impression of the platform. However, when they talked about the platform, everyone talked about the CGM, and very few people actually used the educational materials. They only really used the tablets to view the results from their CGM. During the pandemic, people looked at the materials, but actually across both groups, no one really felt like they needed it. They kind of, you could see on the back end, how many people have accessed it, and it was very low. And there's a prevailing lore, I guess, out there that seniors are not facile with technology, that they don't like it, they're not going to use it. That wasn't really true in our group. They needed some support for sure, needed some help. The study team was great with that, but the technical barriers were not insurmountable. Now, certainly these are people who chose to participate. Some people didn't want to, so there might be some selection bias, but they all were. People really did well with the technology, so I think that's something to kind of think about. They definitely required some assistance, and that we wound up adding a whole visit just for technical assistance, but they did okay. So I think that's helpful to think about. So in terms of dissemination, we have some papers out about the pandemic, what happened then, and then overall, we're still kind of working through some of the analyses, and so some of those will come out afterwards, and then we can see what happened overall with this work. So now let's talk a little bit about the future and maybe what we can learn from some of the projects and kind of thinking about what happens next. So at the organizational level, some things to think about are really stratifying populations and then stratifying the support that's provided to them. So what that means is, thinking about, who might benefit. You stratify maybe across cultural considerations, age, disease state. There's a whole host of ways to stratify. And then when you're thinking about all those different types of groups, then perhaps the educational needs are different. Perhaps we need to think about culturally competent kind of materials in different languages, making sure those are culturally competent and not just a straight translation, all those types of things. And then, the streamlined multidisciplinary workflows, number 3, that is something that, all of these things are studies that we looked at. We all looked at things that were part of a particular effort. But then how do we maintain this? What happens for organizations afterwards? So really kind of thinking about how we don't add too many steps, how we don't kind of incorporate things into existing workflows is something that I think more attention could be paid to. And then letting providers know, some providers who are really on top of things or maybe have an interest in informatics might be aware of what's happening in this space. But, I'm not sure that a community-based provider who is not that interested in technology and had to be, kind of dragged kicking and screaming into the EHR world is going to be up on the latest in the Apple Watch. And they might not want to be, which is fine. But then, maybe there might be ways to also provide some tailored and targeted education that way. And then also thinking about how to incorporate data. When we did interviews for the first study I talked about, the AFib one, most providers that we interviewed were shocked that of the lack of integration between all of these watches and the EHR, because when you set it up, it asks you, do you want to connect to my chart or do you want to connect to the portal? And so you think that, that means that it'll all be there. However, that's not true. Only structured data will be sent, and where it appears is different. ECGs are not sent automatically. So there's all these other kind of nuances that are not necessarily apparent until you need it. And then when you need it, you realize what the nuances really are. And then typically, this is something to think about with patient-generated data in general. Where they don't appear with everything else. They're sort of off to the side. They're not necessarily easy to access. So those are all things to think about as well. Now, in terms of what might be next, as I mentioned, the regulatory and policy landscape is evolving. And I think that having done work with this in the past, I think that there's variance in the appetite to change and the appetite to address some of the changes that are happening. However, the technical innovation continues to happen. So whether or not people are ready, it is coming. And so it's important to consider that, not only from an end user perspective, but also from a provider perspective, from an organizational perspective, because if there are technologies that are available and being used, people will ask about them. So then what do you do? But certainly there is, there is provider burden. People are kind of sick of, having more and more things to look at. So there is the potential to perhaps use analytics or AI to maybe look for trends, but then that raises a whole host of other questions. So those are all things that are kind of for us to grapple with in the future. And then I talked about patient-generated health data already, but then there's also equity considerations. Who gets referred to what? And then what are the limitations of the devices? So for example, anything light-based like a pulse ox or even some of the smartwatches, will vary based on skin tone. And then medical societies have come out with white papers saying, yes, consumer wearables have a role to play, or yes, AI is important, but they haven't necessarily come out with what to do for providers. And so those are things that providers might really rely on. So those are some other things to think about for the future, for the field. So going back to the learning objectives, hopefully you learned something about all of these three things. Otherwise, I will have failed, so hopefully you did. I think we covered all of those items. And then I just wanted to thank the project teams across institutions for all of their time, and particularly the participants, both the providers and the patients with whom we spoke really spent a lot of time with us. And it was, particularly for the patients, it was really, it was an honor to hear their stories and let us be part of their work. And with that, I'd like to thank all of you for having me. I've had a lovely visit so far, and I think we have a couple of minutes for questions. Thanks.
I'll take the chair's prerogative. So the question that I have is, as we think about how to incorporate patient-generated data into the EHR, to your knowledge, are any health information exchanges, looking at how to incorporate patient-generated data, how to make that, because they could be potentially a conduit to take the data from the patient and make it available to providers, as opposed to, everyone sending it to, I go to IU Health this week and then I go over here to a different provider the next week. To your knowledge, is any of that happening?
So not as part of this work, but as part of another piece of work that I was working on, we actually talked to a few health information exchanges about the potential. And I would say there was cautious interest, but no action. So, and it's tough. I understand why, because there are troubles with write-back. There was troubles with it being incorporated in the same place across EHRs in the same way. Oftentimes it's not structured data, it's unstructured data like symptom trackers and things. So I think that's really, I should have probably added that to the future directions. So maybe I'll do that for the next time I give this talk.
All right, any other questions? If not, join me one more time in thanking Dr. Haque for her talk today.
Thank you all for having me.